Good afternoon, and welcome to the Iowa Ideas Conference and our session, What It Means to Have AI in Healthcare. I'm Tom Barton, the Gazette's Deputy Des Moines Bureau Chief, covering Iowa politics, including the Iowa legislature and campaigns. I'll serve as your moderator, helping to guide today's discussion and conversation as part of Iowa Ideas, which seeks to explore the issues, address challenges, and share the big ideas that will shape the future of Iowa. I'd like to recognize our presenting sponsor, ITC Midwest, which helps make this virtual conference possible. A reminder that audience members can submit questions to our panelists through the Q&A function. This session is also being recorded, and closed captioning access, I believe, is also available. As I mentioned, if you have questions, please put them in the chat, and we will do our best to address those during the discussion. And joining me today are Brett Taylor, Chief Technology Officer at Unity Point Health in Des Moines. Hello, Brett. Thanks for joining us.
Thank you.
And we have Dr. James Blum, Chief Health Information Officer at the University of Iowa Healthcare. Hello, Doctor. Thanks for being here.
Pleasure to be here with you today, Tom.
Great. So let's frame today's discussion. AI is already present in healthcare, from note-taking to chart summary generation and image analysis. Today, we'll explore how it's being used, what it means for patients, and what the future may hold. So to start this out, I'm going to throw this to both panelists. AI has become a buzzword across industries. From your perspectives, what do we really mean when we talk about AI in healthcare?
Dr. Blum, you want to start?
Thank you. So I think if you're going to look at AI at a really high level, I think we would define it as technology that has been developed to emulate human decision making and or computation that we would do by hand to assist in higher level functions that we would seek to achieve as in our daily work. So if you distill that down, I think it's really saying how can we have machines, computers in this case, really assist us in making decisions, whatever those things may be. And that could be a decision everywhere from what I'm going to write in a note regarding a patient's well-being to predicting whether or not this patient is going to deteriorate, and that could be over a period of years or a period of hours, to things, where should I make the incision on this patient if I'm doing surgery, or how should I suture this patient up? So it's really a broad scope, but that's what we're really looking at in healthcare from the patient perspective. And then there's a variety of things that we do in healthcare today, which we would consider in the back office, the business side of healthcare, of getting people prior approvals, making sure that they're having the ability to get if there's any charges associated with their care, to get those things paid for, making sure that their insurance provider is aware of those things, and if they have any questions, answering those questions. So it's really AI has penetrated almost every part of healthcare today, everything from direct patient care through healthcare operations.
Right. And Brett, what about you?
Yeah, I mean, I really couldn't state that much better. You did a great job of summarizing. I mean, at the end of the day, it's meant to augment or to aid. It's not meant to replace, right? So I think that's the scary part that people think about. It's meant to replace people, and it's not really meant to replace people. It's really meant to make them more efficient and aid them in things that that would take them longer otherwise, right? And so from that perspective, it is definitely in every part of our business, right? It is definitely helping, speed to, like I said, to billing, to, getting back to and getting answers back to the patients, and as well as providers, even getting kind of weeding through. So like your MyChart even, right? I mean, if you're sending a message to your provider, there's something going through there looking at that and saying, okay, these are the messages the provider needs to respond to versus the care team can respond to. Things like that are happening that are really just trying to help give time back to the provider and the patient. So,
yeah. So what distinguishes tools like transcription AIs from clinical decision-making AI, and why is that distinction important? And Brett, maybe I'll throw this to you.
Yeah. I mean, the transcription part is a huge help, right? I mean, it's really just meant to help capture the conversation real time, make sure that things don't get missed. The provider can focus more on talking to the patient versus taking notes, right? Now they have to go back and take care of that later and validate all that and make sure, but when you talk to true clinical decision making, that's a totally different thing, right? That the transcription piece is really just meant to capture the conversation. The actual benefit of trying to diagnose, I mean, that is a whole nother thing, right? You don't look through your transcription and diagnose. There's other things that can help with that. There's systems built into some of our healthcare systems that can even assist with and speed up that process. But ultimately, it's the provider that has to do the diagnosis, right? It's not the AI that does it, but it can certainly aid.
All right. Brett, can you kind of walk us through how Unity Point is currently using AI tools?
Yeah, I mean, we have lots of, I'll call it lots of implementation of AI tools, right? I mean, all the way from back-end IT systems to, front end, right? And so, case in point today, transcription, right? We're doing some piloting of some, we call it ambient scribe, right? Where the provider is listening to the patient and there's this piece that's recording the conversation and making sure it's documenting, kind of what's said, what's agreed to, capturing all that information. That's kind of some of the other stuff we're doing. I mean, but there's a lot of other areas where it's in use. I mean, it's in use in our billing systems just to make sure that charges are captured appropriately. There are less errors, right? As well as follow up with patients, right? So to make sure that there's text messages back to patients to reminder for their appointments. I mean, there's just all kinds of different use cases where it's in use today that, you really wouldn't necessarily think of, but then there's also areas where it's pretty commonplace, right? Where you would think that, yeah, why not use it there? Now, as far as diagnosis goes, we haven't really started using it for that piece other than I would say, but there's probably some radiology and some things like that where, there's probably some AI tools in use. And then there also goes all the way to the bedside, right? Where, we have what we call there's these telesitter programs where, they, instead of having a person sitting in the room, there's people watching on a camera, but there's some, AI algorithms built into it that watches for certain movement that tells the sitter that somebody's getting ready to do something or they're getting ready to get out of bed, that the movement that they're doing is going to do that. And that actually helps reduce injury rate, reduce fall rates, things like that. And so those are really cool programs that we see today in use. So.
All right. Doctor, same question for you. How is UIHC currently using AI tools?
So at Iowa Healthcare, I would say that Brett covered a lot of the areas that we've been focusing on. We have fully rolled out our ambient scribing, that transcription technology that he was describing, to all of our providers. They all have access to it today. Quite likely, if you come into a University of Iowa clinic, you will have your provider using an ambient technology to document the conversation, assuming that you, as a patient, agree to it. They're also using extensively AI chart summarization and AI clinical intelligence to help provide our providers a better understanding of the complexity of their patients. We provide a lot of the really complex quaternary level care in the state from referral organizations with information that's been flowed in from all types of sources, everything from things that's been faxed to us to things that have been sent to us electronically from another system to things that are in our native electronic health record. And we're using a set of AI tools now to help bring those pertinent diagnoses and history forward to the provider rather than making them rifle through all of those documents piece by piece, one by one, looking for that type of information. And then on the business side of the hospital, a lot of things that Brett was saying, using AI in our denial and appeals processes, AI in our documentation improvement efforts to make sure that we're documenting the right things, to make sure that everything from our quality metrics are appropriately reflecting what the complexity of our patients to how we process and code those documents to make sure that we're appropriately reimbursed for the services we're delivering. So really across the board, we've been using AI to change the way we've been delivering care over the last couple of years.
Yeah. I believe either earlier this week or maybe it was last week, you spoke to my colleague, Bailey Chehan, for our Curious Iowa series. And I think in that conversation at UIHC, you said that there hasn't been a single instance where AI compromised patient care in its first year of use. I guess what makes you confident in that, and what guardrails are in place?
Yeah, so we are not aware of a single instance. Let
Okay.
me say that. It's hard to disprove a negative, right?
Right.
But we have not had one report of an untoward outcome because of an AI based tool. And we receive all types of feedback regarding the care we provide every day to make sure to help continue to improve what we do every day at the University of Iowa. And so we've not received one notification that's come across my desk that said this patient was harmed because of the AI, that the AI misguided me, that the AI provided documented something incorrectly, that I didn't catch and change, all those types of things. And I think part of the reason is exactly what I just said there, is that for all of our AI, we have humans in the loop, right? We don't have any AI that's running right now totally autonomously directing the care that we provide. So really, as Brett said earlier, these are tools that are there to help augment the care we deliver. In fact, many organizations are using this word augmented intelligence rather than artificial intelligence to emphasize the fact that we have humans in the loop, double checking these things. And the tools are there to make us better, both more efficient and safer, and deliver higher quality, but not to replace the humans that are providing those services today.
Yeah.
There's always that manual check, right? You got to have, especially when it comes to diagnosis and patient care, there's always got to be that manual step to make sure that somebody's looked at it, verified it, and signed off, said, yes, that is exactly what I am signing off on, right? And so I think that's why, to his point, that's why there's probably not been any of those cases, because, well, there is always going to be somebody looking at that, at least for the foreseeable future.
Yeah. Brett, well, and actually for both of you, but maybe I'll throw this to Brett first. How do patients react when they learn that AI is being used during their visit? Are they embracing these tools? Are they skeptical? Have you noticed generational differences?
I mean, it's a mix, right? It is, and I believe it is a generational thing, right? There are some, because I think of my parents and and certainly my aging parents. I've had to take to the doctor quite a bit, and they are very skeptical of those types of things, and it's just because there's just not that trust level there. But and in other generations, they've grown up with it. It's always been there. It's just advanced very quickly, right? And they trust it because, well, they've seen it. They grow up with it. In fact, that a lot of patients now come in and they hand the doctor a piece of paper and said, "I found this online. I went through a Copilot or whatever, and it said I have this," right? And so, for that particular reason, I think they're more willing to embrace it than in previous generations, I would say, for sure. But it's a mixed bag, right? Some people just do not trust it. I know people who, basically say, I don't want anything of mine involved with it. And as a patient, as Dr. Plum said, when you come in, they should tell you, we're going to use an ambient scribe. They have the right to say no. They can tell you they don't want it used, and you have to honor that. So.
Doctor, I guess same kind of question to you. How are patients at UIHC reacting when they learn of the use of these AI tools?
We have been very pleasantly surprised by the reception of the use of AI-based tools. We instruct all of our staff to discuss the use of ambient technology with the patient before we use it. We've had, I'm not saying that no one says don't use this, but I would say that we've had the vast majority of patients, meaning in excess of 99% on average, saying not having concerns about using the technology. In my clinical practice, I've had one patient ask for me not to use the technology. And it was because they wanted to discuss some, let's just say, questionable activity. And so other than that, I've had 100% utilization of the technology when I explain to them. And part of that discussion is I say to them, this technology helps me take better notes, which it does. My notes have improved considerably, and helps me pay more attention to you and engage with you during our conversation, because I'm not consumed trying to take notes or write or put things into the computer. Um, and so it really helps, I think, the patient interaction. And we've received, when we first released our ambient technology, I got all types of emails from our staff saying, "Thanks for bringing this technology." But the most surprising thing was I would get these random emails from patients saying, "This is the first time my doctor really seemed to pay full attention to me and wasn't consumed on the screen. Is there any?" I actually got one saying, "Is there any way you can make my doctors use this every time I see a physician at the University of Iowa?" And so to me, that was a huge win, because it's not just making our providers' lives better and potentially helping us provide technically better care. It really was helping to restore the patient provider relationship, and that makes that's, I would say, in an era where trust has been lost to some extent with folks in healthcare. To me, that's a momentous step forward.
Yeah. Who oversees AI use in your organization? Is there a board, a director, or a governance team? I guess, what does that oversight look like in practice?
Today, AI is being infused in all types of technologies throughout healthcare. And so we have established that AI acquisitions and the integration of AI technologies will be done through the existing pathways we have to procure technology. So if you're buying a new ultrasound machine and it has some fancy AI features in it, well, you're going to use your typical way that you would procure an ultrasound machine. Some other healthcare organizations have separate AI committees, and anything that has the word AI in it has to go through that committee. We've chosen not to do that. But what we have done is we've created a additional stop along the way for AI-based tools, that the AI is component of whatever is being acquired is routed into an AI governance group that basically reviews the AI component of whatever you're buying and really tries to answer 4 questions. The first is, what is this trying to do? How did they train it? Does that training appear appropriate, and is it performing accordingly to support our patient population? And what are the risks and benefits of potentially using this technology? And as we offer a recommendation from that committee that then goes back into the purchasing process. And obviously, if we think that something is flawed, usually it stops the purchasing process for that technology, or at least the AI component of that platform.
Yeah. And Brett, what about at Unity Point? Who oversees AI use in your organization?
Yeah, that's a great question. It's very similar, actually, to Dr. Blum. We have normal channels that we follow through from a purchasing of new solutions. Then it would follow that, but then there is an AI governing committee that actually reviews then the AI component of it as well. It's very similar. We ask all the same questions. I would say the one caveat is we try to look at also too, is it an isolated version of the AI instance, meaning it's just our data, it's not commingled with others' data versus being commingled with others' data, and that's a big deciding factor. And then the last piece of that is we have a security review process that evaluates. It goes through a legal and compliance components that make sure that it meets all of the requirements from a HIPAA requirement, and that's the final step for us. But that all things go through that. AI, that's not unique to just AI. So
we have a very similar process to that as well. And I should have mentioned that for our security signs, and then I should have mentioned that for AI models that we're implementing or those types of things, that AI group is charged with periodically reviewing how those things may be performing. So it's not a one and done. We continue to assess the performance of whatever AI-based technology is coming forward, but we assess the AI component of that technology, not necessarily the other components of it.
All right. Doctor, you described how AI scribes give providers back time with patients. I guess, what has that meant in practice for doctors and nurses? Has it changed the way you or your colleagues deliver care?
I don't think it's changed the way we deliver care, other than we're less distracted. And we've studied this fairly extensively at University of Iowa. And what we found is that it does appear to save people some time, or at least it's perceived that they save some time. We still see people doing a considerable bit of work at off hours and nighttime for a variety of different reasons, we think. But what they've said is that they are not task overloaded as they are working with patients. They are able to focus, and with that, they feel far less distracted, and that's resulted in far less burnout inside the clinic. It has been really perceptible using very validated instruments that we've been able to reduce the burnout in our workforce considerably simply through the introduction of this technology.
Brett, have you seen
Which is remarkable.
Yeah, my apologies. Brett, have you seen similar for Unity Point?
Well, we haven't completely rolled out ambient scribe for ours yet, and so, but I would say certainly where we have, the comments have been pretty overwhelmingly beneficial, right? I mean, they're very thankful for the technology, and it does give them a considerable amount of time back. To Dr. Blum's point, though, there's still a lot of stuff that happens, and not even the provider side, just considering other spaces where AI is used. They're using it and then they're filling their time with other things, right? And so it's not like they're less busy, they're just doing more things. And so I think provider space is probably very similar, right? They probably still have a lot of stuff they have to do, but certainly we will have more data on that once we roll our ambient scribe out more company wide. But we're still in I'll call it a pilot phase of that, and so we haven't fully rolled it out yet. But I'm excited to see it go because I think it's going to be helpful. So.
Yeah. We have a question for the audience. I think this might be aimed at you both. The question is, do you have in-house developers of some of the AI tools which would allow you to quickly modify the algorithms to meet your needs? I guess maybe Dr. Blum, maybe we'll start with you on that one.
Yeah, so we do have in-house developers that do some work for us. They are mostly working in what we call the predictive AI space. So patients that might become sick, patients that are at risk for developing certain conditions. Our ambient technology, our chart mining technologies, we've predominantly procured in a partnership with the companies. And when we need to make changes, we work with the companies, both of which have been very receptive to our questions and concerns. And they sometimes make changes faster than we're able to accommodate changes inside our own facility. So I would say it depends on the technology that's in question.
Brett, what about at Unity Point?
Yeah. Similar answer, right? So most of our in-house developers that are leveraging AI are primarily analytics driven. And so that's primarily where those developers sit. We do have some developers in-house that do work with some of those tools. And that is, I'll call it ramping up, right? We're seeing more and more requests come in for certain things. But to Dr. Blum's point, a lot of the AI that we purchased is vendor purchased, and so therefore vendor supported. And so we don't generally touch the development, but we do have in-house developers, and they do some development with that. But it's just on a smaller scale when compared to the clinical apps, because the clinical apps, again, those are purchased. We don't generally touch any of that. That's a vendor supported application, and we would rely on them to make those modifications.
All right. Brett, in our pre-panel discussion, you had spoken about hallucinations or AI generating inaccurate or misleading information. Why, I guess, hasn't this improved, and what safeguards are needed?
Yeah, that's a great question. It's interesting because you would think that over time that would improve. But unfortunately, I think the fact of the matter is that the bad data that's getting into these large language models is just as bad as it was in the beginning, if not more so, right? You have people that put stuff in there that just doesn't belong there, and it's just going to take time for them to figure out how do they safeguard or how do they remove that bad data? Because how would they know what that is, right? And so I think that's the big problem is trying to identify that bad data. And I think the safeguards are going to have to be put in place are, it's especially when it comes to healthcare, it's going to have to meet certain criteria where it's two or three or more checkpoints that confirm it versus one bad one, because it seems like that one bad one, that one outlier piece can just throw and skew off the whole language model, and it will give you that inaccurate data, unfortunately, right? And so I think there's some work that needs to be done there, but I think the problem is this industry is moving so quickly. They really haven't been able to figure out or figure out how they're going to improve on the hallucination side of the house, to make it reliable enough yet, right? It's coming. They'll figure it out. It will get solved for. It's just right now things are just moving so quickly. I think it's hard for them to address that matter.
All right. Cybersecurity is kind of another double-edged sword. How are hospitals defending against AI-driven attacks while also using AI to protect systems? Doctor, is that something you can field?
Yeah, we have a very robust information security office that is actually shared between the university and the healthcare entities under the University of Iowa umbrella. There are definitely AI components that are integrated into our firewalls and things that look for phishing attacks and other types of cybersecurity type breaches and attacks. That's at a high level. What I would say is we've definitely noticed an arms race escalation with the sort of folks that are interested in trying to attack healthcare enterprises, and what was once considered to be untouchable. Even the hackers said we're not going to assault hospitals at one point in time. It was unhonorable to do so. Unfortunately, those days are well behind us, and so now we really do take information security just as, if not even more strongly than I think some financial institutions. Just because of the risks that are associated with a potential breach. In a financial organization, you may lose a bunch of money, but in healthcare, you could lose a life. And so we really recognize the importance of having an extraordinarily robust cybersecurity instance.
All right. I'm curious, how is patient privacy protected when AI tools are used? Where is the data stored? How long is it retained, and who can access it?
Yeah, so as part of our security reviews, first of all, we make sure that all of our vendors that we use, let me begin by saying that in modern healthcare, data has been moved around for the last decade quite readily between health systems and various vendors that do all types of things to help make the health system work. Everything from entities that validate quality to your insurance company to entities that work on payment, data flows. With all of those entities, we make sure that they're adhering to very strict high-level security standards that are federally and state mandated. And in fact, we have some requirements that go above and beyond that. In particular to our AI vendors, we've implemented a few rules that are very strict. The first of which is our data isn't used for training AI-based models with, for example, our chart summarization tool or our ambient scribe. So the data from our patients is purely used for the delivery of care. Additionally, they only retain the data that is necessary to continue whatever service they are providing to us as an organization. So with our ambient technologies, the transcription of the note that is taken, first of all, there's no recording with the technology we selected. We explicitly selected our technology because there is no recording, so there's no identifiable voice. In that, what it does is just makes a transcript of the conversation in very short segments. And that transcript is then processed, then sent back into a note-based format, and then the transcript is erased. And so we've really minimized the amount of data that can go out to our ambient vendor. And that was one of the reasons we chose our ambient vendor, because we felt that it really minimized the data security risks. For our chart aggregation tools, again, managed with very high levels of security. That data is occasionally purged if a patient isn't being seen at UIHC any longer, to help minimize the amount of risk attributable to any one system in the event there was a breach.
Brett, I guess, how is Unity Point addressing this issue of patient privacy protections when AI tools are used?
Yeah, very similar, right? I mean, we don't, that is part of our security review process to make sure that none of this stuff is stored that doesn't have to be. It's very minimal and it can't be identified. And again, we also look for tools that are isolated with just our data. They're not commingled with others. That's one of our major requirements of any AI vendor, is that we make sure it is not commingled with others. And anytime it needs to be, so like even some of our AI tools that has to go out and use something from the web, right? It will actually take it, pick it apart from anything that's identifiable, go out, retrieve the information, come back, and then piece it back together on the inside, right? And it's all within our four walls, never actually goes outside of our four walls, which is kind of nice. And so we always look for those kind of solutions. Obviously, where you can't, you just need to make sure that that is safeguarded as well. We use vendors that obviously are, you know, they meet all the regulatory requirements, whatnot, and the patient data is generally unidentifiable. And back on the security side, I wanted to talk about that just real quickly. On the cybersecurity side is, you know, while I would never really talk about specifics about how we do or what we do, because, you know, we don't really, I mean, it's one of those things where you just have to be careful about what you say, because, well, you don't want people to kind of know how you protect your four walls. But I would tell you, it's never ending. It is always moving. You could never have enough money to protect everything that you want. There's not even enough money, and you know, we can't spend enough money to do that. And it's a very sizable portion of our overall budget, right, is protecting this data. And so you're constantly reevaluating. It's like a quarterly basis. You're reevaluating where are you spending the time and effort to go after and protect, and you're moving it around constantly to make sure that you're shifting with where it changes. And that's gotten now to the point where we almost need to start reviewing it monthly, because it's changing that fast. You know, and there's this new concept that's really cool that's coming out that we have been looking at, and it's called guardian agents, and it's really these bots that you put out there that just go look for and hunt down cyber incidents that might be happening out in your environment. And it's like constantly, never sleeps, never stops looking. It's always going. You know, that kind of new technology that's coming is just, you know, very cool. And it's, you know, it's ultimately how we're going to be able to try to combat, you know, what's happening in the world, because they're using it against us all the time, and they don't stop either, and they never sleep either. So, yeah.
I believe you've both said that, but I just want to double check this. The patients have the opportunity to opt out of AI tools being used in their visit. I guess, how do you communicate that choice?
So we allow them to opt out of the use of ambient technology. You know, we can't necessarily allow them to opt out of use of, for example, in radiology, a radiologist using AI to help identify potential lesions that they need to look at, right? But in terms of ambient technology, we basically, at the beginning of every visit, we instruct our providers right now to say, we have this AI-based tool. It helps me take better notes. Do you have a concern with me using it? It creates a transcript. There's no voice recording, and it'll help me pay better attention to you. Do you have any concerns with me using it? And if the patient says, I have no concerns, we go ahead. If they have concerns, one thing we don't try to do is encourage our providers to try to talk people into using the technology. We sort of say, let it go, and then we provide them information on our website if they want to read about it, and maybe the next time they come in, they'll entertain using the technology for a better experience with their provider.
Yeah, it's same here, right? It's generally the direct patient care experience where they can opt out. The back end processing and things that happen are generally incorporated into the tools. We generally don't even have much of an opportunity to say, yeah, don't use that, right? I mean, it's built into a lot of processing that happens behind the scenes today. And in that particular case, there really isn't much of an opportunity to opt out.
Doctor, you mentioned AI tools being used in radiology or imaging. I guess can you elaborate on that into how AI is being used? I guess in that field, how is this helping radiologists, doctors, or nurses as they're looking at imaging? How's that helping them?
Yeah, so that's a great question. AI is being used throughout the radiology process and imaging process, everything from prioritizing what scans should be looked at to, and we're currently rolling out a number of these technologies, and where we are with each of them, I'm not exactly sure, but because I'm not a radiologist, but everything from this is you've got 5 stat head CTs to read because of people that may have had a stroke. Which one is most likely to have has something that a radiologist is to have actually had a stroke, right? So you move that study to the number one study to be read, right? So prioritization is an area that it's being used in many health systems, and we're moving in that direction as well. To actual image interpretation and processing, where not that the AI is going to say, this is the diagnosis for this patient, but it's going to say, this is an area of concern that you need to pay extra special attention to. And so, because the AI thinks that there's a potential problem. And those are really the kind of 2 areas that AI is being used that directly impact the patient. And then there's also a set of tools that are being used afterwards now to appropriately code and bill for those patients that used to be done manually, that now AI is able to assist in making sure that patients and insurers are billed appropriately for the services that are delivered.
All right. Again, Doctor, in your conversation with my colleague, I believe you had suggested that by the 2030s, AI might even assist in surgery, identifying certain structures and labeling them for the surgeon and guiding incisions. How realistic is that timeline?
I think 2030 is the way that the rate technology is moving today. I think that's not unrealistic, particularly with the introduction of robotic surgery, where you have the surgeon is still operating the robot, right? The robot's not doing anything autonomously. I don't think we'll be at the point where the robots are doing things autonomously either. But you already have in research settings where the robots are the computers behind the robots are labeling are labeling structures. You've actually had in animals demonstrations of technology where the robot has actually done the surgery, the surgery. So I don't think it's unreasonable to think that in the next 5 years that labeling of structures will become a feature that is available in robotic technology. I think that's a very reasonable thing to do. As an example, right now, today in certain endoscopic procedures like colonoscopy, there is AI assisted technology that looks for additional lesions, polyps that might be cancerous, FDA approved, that says this, you better really look at this little bump inside someone's colon and potentially get a biopsy of it because it looks like it might be cancerous. That's available today and is being used across in many systems. So I think the answer to that is it's here today and will continue to expand its use into the surgical domain in the not too distant future.
You mentioned automated surgery for on animals or on pets. I guess how effective has that been, and do you see that eventually happening for humans?
Yeah, so it's been done as a demonstration, as a research demonstration that it's possible. Do I see that happening someday, where a robot will actually be assisting surgery with a surgeon potentially being there, overseeing it? The answer is someday. The answer is yes. Do I see that in the next 5 years, 10 years? Probably not. Would be my comment. The first autonomous flights across the Atlantic happened in the 1950s, right? We still don't have airplanes flying without pilots in them. So aviation is very conservative field, as is medicine. So I don't see this happening in my practice career that we're going to have automated surgery, but maybe in 2220, yeah, maybe we'll see it in 100 years, a couple hundred years. So,
all right. Earlier this week, President Trump signed an executive order related to using AI in pediatric cancer care, or I guess using artificial intelligence to transform the way scientists fight childhood cancer. However, that move comes amid cuts to hundreds of millions of dollars in science research grants, proposed cuts to the budget of the nation's primary agency for cancer research and training. I guess, what do you make of the president's executive order?
Yeah, I think it's more a directive to focus funds into areas where people are already, there's a lot of excitement in focusing funds. I'm not sure how much impact the order will actually have relative to basically the president just saying he supports the use of AI in cancer research. But if you look at where NIH funding has gone over the last decade and the amount of NIH funding that is in AI-based research, for the last 20 years, have participated in essentially model development and AI-based research. I can tell you that the amount of funds that flowed into those domains over the last 10 years has gone up exponentially, I believe, with the NIH. So I think the president's order really just reflects a direction of where healthcare research was probably going.
All right. Brett, I'm curious, from a governance standpoint, what do you think needs to happen, I guess, at the organizational and regulatory level to make sure that AI evolves responsibly in healthcare?
Yeah, I mean, I think that's a great question, and it really is around that, making sure that there is some sort of human in the middle, right, or human in the loop piece there, because at this point in time, it's a great tool, it's a great augmentation, and it's a great aid to a lot of our providers, as well as just in general, technology in general. But it's certainly not something that I would say we would want to allow it to just go off and autonomously do stuff without some sort of, I'll call it review, or some sort of manual intervention to say, yeah, that looks right. When it comes to healthcare, right, especially, you don't want something bad happening because you allowed that thing to go off and it made a poor decision. There still needs to be some sort of human in the loop and making sure that that's being watched and there's some oversight there still. And I think that's the part that, allowing it to evolve and evolve responsibly, there still has to be some manual intervention and manual oversight. And that's going to have to continue for some time in the future, I think.
Doctor, anything to add to that?
I think the one only thing I would say is that I think we are at risk of stifling innovation if there is too much regulation that gets placed on AI in healthcare right now. There's always risks involved with innovation, and obviously having humans in the loop and making sure that safety protocols are in place is important. But I do think that if you converted all AI to having the oversight of the FDA for anything that's developed in healthcare right now, rather than guidelines, particularly for things that are low risk with people in the process, I think you would risk potentially really harming more patients than helping them with slowing AI innovation.
Yeah.
Can you talk about what the regulatory process is like currently?
The current regulatory process for AI in healthcare is relatively moderate for things. It has been anything from pretty minimal to for devices, for things that are not medical devices. The trick comes when you start talking about AI that moves into the medical device realm. And right now that is profoundly onerous if you want to sell something as a medical device, as it probably should be considerably challenging, because you are then talking about things offering actual diagnoses or making significant predictions of of people having imminent disease. And so, but there was some discussion about moving that type of regulation to things that might simply say, this patient is at high risk for high cholesterol. Why don't you check their cholesterol? And if you had to do everything to validate something like that, um, uh, there's the risk that you might not have alerts or other types of information conveyed to providers that could really help improve care that are very low risk. The risk of checking someone's cholesterol is a blood draw, right? That they're likely to have anyway. And so the last thing you want to have happen is someone not receiving that information to do something that potentially could be very diagnostic and change someone's life because you have an excess governmental regulation saying that you didn't jump through all the hoops to recommend something very simple like that.
Yeah, but I think what we're seeing though is a reaction to the very quick pace at which AI is starting to take off. And so you have people just pumping the brakes a little bit and saying, whoa, hold on, that we weren't quite ready for that, right? And we're no different, right? UnityPoint took a little while to get our governance stood up to figure out where are we going to allow it to be used, where are we not going to allow it to be used, and we're still kind of working through some of those. And so I think you're seeing some of that in some of the regulatory space as well. Is it's evolving faster than they can actually put regulations around it, and so I think in some cases they're over regulating in order to stop things so they can figure out what they need to. But you're right, some of this low risk stuff really needs to be, taken back and saying, okay, that's definitely more beneficial than it is harmful. Let's allow that to move forward. But I think that is just a reactionary thing that we're seeing because everything moved so quickly.
If we look ahead 5-10 years, what's one development in AI you think will most transform care for Iowans? And Doctor, maybe we'll start with you.
Yeah. That is a really good question. 5 to 10 years. I actually think it's going to be the genetic space overlaid with AI. So, with changes that have come across in genomic sequencing, our ability to essentially extract large parts of what makes us each unique is going to become a reality. And then the only way to interpret that data and make sense of it is going to be with artificial intelligence techniques. But the ability for us to say you're at risk for colon cancer, and it's not just one gene today that we test for, but it could be a bunch of genes put together that happen to make you unique, right? And give you that risk could really change your life, change the trajectory of of what happens. All with routine screening and things that we would do. On the flip side, for someone that's very low risk for such diseases, and we know, there's no family history, and genomically, there's nothing that maybe we don't need to invest as many resources in screening you, right, as we would invest in screening this other person. Just makes the health system more efficient. Right now, how we determine you need a colon cancer screening, aside from this genomic thing, we get a family history, and then we do a colonoscopy, and then your gastroenterologist sort of has some guidelines. It's very crude what we do. And so that the reality of precision medicine coming forward it will only be realized with AI, but I think we're going to see that happen in the next 10 years.
What about in terms of devising new treatments, like new cancer treatments?
Yeah. So AI is definitely in the being used in the drug development realm. It's been actually used for a couple of decades. That technology has gotten considerably better and is continuing to help make potential chemical targets that become drugs more readily identified. So I think you're going to see that definitely come forward as well. So advanced treatments through that combined AI-based discovery process will definitely be something we see.
All right. Brett, 5 to 10 years, what's one development in AI you think will most transform care for Iowans?
Yeah, I mean, that's an interesting question. And I think Dr. Blum kind of hit it on the head, right? I mean, I've been doing a lot of reading around AI, and this is something that's actually been going on for a little while now, but it's certainly advancing more. It's like this digital twin, right? It basically, it's like it knows how you will react to medicine. It knows how you will react to a procedure. It knows how, based on certain things. And I think that's just a really interesting thought of knowing that, if you go to your doctor and they have this ability to look at, if I prescribe this to you, or if you do these things, your body's going to react this certain way. And there's this research being done around this. I've done some reading on it, and just seeing how that is progressing is just really cool. And it's kind of neat. But I think the ultimate thing is predictive analytics and understanding what's coming, how, like that is the piece that's really getting better and better, because these AI models can do it so much faster and so much quicker and so much better than they used to be able to do it. We're going to be able to predict things and see things coming way before that they ever happen. And I think that's just really going to be a game changer when it comes to trying to get ahead of healthcare in general, for Iowa in general, but for everybody. But I think that will be a game changer to make sure that we get ahead of certain things, that we can see it before it gets here, and we can address it, years in advance, versus waiting for it to happen and be more reactive like we are today.
Yeah. Question for you both, but I guess I'll start this with you, Doctor. I guess, what have you learned from implementing AI, and what tweaks were needed?
That's a great question. I think the thing we learned actually was how readily everyone's willing to use this technology. When you look at the introduction of other healthcare technologies, I think many of them were pushed on providers because of federal mandates. For example, all these electronic health records that we have today, although in Iowa we had one since really the 1990s, many organizations were incentivized to install electronic health records between 2009 and really 2014 through a federal carrot and stick approach. And it did help us, I think, deliver better healthcare. But that came at a profound expense to the people that actually did the work of delivering that healthcare.
Yeah.
I don't know any physician that practiced in the paper era that says, like, oh, my life became so much better after we installed our EHR. It's the exact opposite. And what we've found now is, and so when you implemented those systems, you had to do lots of training, you had to do lots of coaxing, you had to do lots of cajoling to get people to learn the system and use it appropriately. These technologies undo a lot of that burden. And everybody is seeing benefit from these AI technologies. So there's been very ready adoption of these technologies without the poking and cajoling that you needed to historically do in healthcare IT implementations. And so I think that's the biggest thing we learned, is that you can deliver great software that's easy to use in healthcare IT, and people will readily adopt it. And once you kind of get to that 30% utilization, 30% of your providers are using a piece of technology, it tends to just start to grow organically inside your health system. And that's what's happened with us. And now we're really targeting the laggards, right? The folks that, that last 15, 20%, 25% of people that just, I like my practice, don't bother me, don't make me use this stuff. And some of them are justifiably, they've got great practices, they're very efficient. It's not, the technologies aren't conducive to making them more efficient or having a better patient interaction. We can't really make them use it. But I think that's the big thing we learned, is just how easy it is to get people to use this technology.
Yeah. I was gonna say, being married to a healthcare person, right? Like my wife is a nurse and has been for 35 years, and it's interesting because this is the one time we get to say we're going to implement something that's going to make your life better, and it actually makes your life better. Because all these years we've said, oh, this is going to make your life so much easier, and it doesn't, and it isn't, right? But this is the time we get to do it, and it's real. So that's exciting. And as an IT professional, that's exciting to be able to provide something that actually does that, especially seeing what caregivers go through, like the doctors and the nurses, and seeing that the burden that this has put on them all these years, and now we can actually give them something back. So
all right.
that's exciting.
Thanks. We got about 5 minutes left. Hoping we can do kind of maybe just a quick lightning round of closing takeaways. And so these will be questions for the both of you. And Doctor, I'll start this one with you. One misconception about AI in healthcare you'd like to retire?
I think that the risk that it poses to patients, both in the privacy domain and in the potential harm. I think that I think the privacy concerns are really no more than existed prior to the introduction of AI. And in terms of patient care delivery, I would much rather, as a patient, be treated with a doctor that's using AI than a doctor that's not using AI today.
All right, great. Brett, one misconception about AI in healthcare you want to retire?
Yeah, I agree that it's a bad thing, right? People think it's a bad thing, and it's not. It is a good thing, and it's here to stay. And people should embrace that. And I do think that it is a good thing, and it's something that people should not fear. They should embrace it and understand it is way better. I'm with Dr. Plum. I would much rather have a provider that's using it to their advantage to help me versus somebody who's not. So,
all right. Brett, we'll start here with you on this next one. One guardrail you'll never compromise on.
oh, that's a hard one. So I think for me, it's it's really just taking and if I don't believe it's going to work and I don't believe it's for the better, I'm not going to put it in. Right? It's one of those things where I'm not going to compromise on that part. If it's for something that's for the betterment of the organization, I'm 100%. If I see that it is not, I will not do that. I will push hard not to let something like that happen, right? And so, for me, it is all about not compromising patient care and not compromising patient safety and their data, right? My job is to help protect their data, and if it's going to put that at risk, then the answer is no. And so those are the areas where I have a hard guardrail.
All right, Doctor.
I would agree with Brett in his sentiments there. The one thing that I would say in addition to that is that you have to have people that understand AI vetting the technology before it's acquired. That is and implemented. That is something that you have to have happen. It's too easy. I think Brett would agree in anywhere in technology to be sold snake oil. It is incredibly easy to be sold snake oil in the AI domain. And so you really have to make sure that people that understand the technology are the ones that are assessing the technology.
All right. All right. Last one. And Doctor, I guess I'll throw this to you. Maybe we've already hit on this, but what advance you expect by 2030?
Advanced by 2030. I think the advance that, so this is something we haven't talked about. I think your interaction with the healthcare system is going to fundamentally change by 2030 in terms of when you need an appointment, when you need to understand your lab results, something like that. I think AI is going to fundamentally change those interactions and it will make it faster and easier for you to get an appointment at the time you want it. That will get you information back from your chart when you first see it, when it becomes available. I think a lot of that back office type of work, or maybe I shouldn't say back office, that forward facing interaction that you have with the health system today, for which you're dealing with a person and they're not available 24/7, you're going to be able to get those things done 24/7.
All right, Brett, what about you?
Yeah, for me, it's the technology, it's the wearables, right? I mean, it's going to be, today everybody has them and they're looking at it on their phone, but a lot of that information doesn't get back to your provider, and there's really not a lot of action taken on it, right? I think it's going to continue to advance. There's going to be a lot more things that are available for wearables, and that information is really going to help treat you better. And that information can get back to your provider easier, and that flow is going to get figured out somehow. There's going to be some better interaction there, so that when you walk in the door, they already have all the information they need. You don't have to sit down and explain all the stuff that's already happened. They have the data. They have all your information from your Apple Watch or whatever it is at the time, right? Whatever the new technology is. I think that's going to continue to advance, and it's just going to get better and better. So
yeah. All right, well, that's our time. I want to thank our panelists, Brett Taylor, Dr. James Blum, for their insights, for participating. And thank you to our audience for your questions and your interest. And thank you again to our sponsor, ITC Midwest. Up next in our healthcare policy track at 3 o'clock, it's weighing the cost and benefits of anti-obesity drugs. Anti-obesity drug use in Iowa appears to be higher than in neighboring states, and Iowans will likely get a better idea of financial impacts as Iowa, HHS, and DAS are tasked with reviewing the cost, effectiveness, and eligibility requirements for state programs. So what's drawing so many Iowans to take them? What are the potential long-term impacts to be mindful of? That'll be discussed in our upcoming session. And then 8:30 a.m. tomorrow morning, don't miss Heather Gudenkoff, Edgar Award nominee and New York Times and USA Today best-selling author. Check out that keynote. I'm Tom Barton. Thanks, everybody, for attending. Really appreciate your time.